to assess the situation? Like, what would be your next steps if the progestin challenge was negative?
So if the progestin challenge was negative, my next steps would be to, figure out what her estrogen level is, or perhaps um, do like an estrogen progesterone challenge. I've seen that as well.
And how would you instruct the patient to do that?
I would have to look up the dosing on that, but the general theme is sort of the same, that you give estrogen in the first part of the cycle and then progesterone in the second part of the cycle, and see if there's a bleed. And again, that's sort of to see if there's an intact outflow tract at that point.
So let's say the estrogen progestin challenge is negative. What would be your concern?
So now, I would expect a bleed if I'm giving her both estrogen and progesterone. So at this point, I would be concerned that perhaps she has scarring of her endometrial lining or some sort of outflow tract abnormality.
What type of outflow tract abnormality?
Like a septum, vaginal septum.
Even though she's had two children?
Or like asherman syndrome and scarring of the uterus. Those would
Anything
be
else that would be your concern?
stenotic cervix or some sort of issues with laceration or damage to her cervix.
So how would you treat Asherman syndrome?
Asherman syndrome, I believe, is treated by, well, first of all, because I don't have much experience in this, I don't think that I would be undertaking treating this on my own. I probably would be asking for help from like a reproductive endocrinologist who most likely has more experience with dealing with Asherman syndrome treatment. But it's my understanding that it's, basically hysteroscopy and a releasing of the adhesions that are present within the uterus, and potentially leaving in something like a Foley balloon to help to avoid re-adhesions, and giving estrogen to help heal the endometrial lining. But again, this is all just, I don't know that I don't have like, direct experience with this, but that's what I think they would do.
Okay, let's stop there. What'd you think?
Whew. I've had questions on this case like so many
Oh,
times. Every time
okay.
it's different. Like
Okay.
it's not ever the same route because there's probably so many ways it can go.
Right. Exactly. No,
So
I thought you did. I thought you did well. Just to my understanding, DHEAS is adrenal in origin.
yes. Yeah, I
Okay.
get what you're
So,
saying now. I
yeah,
shouldn't have
okay.
mentioned from
Yeah.
PC.
So,
Part of the
but
different.
other than that, it looked good. Just a little bit on definitions. To my understanding, primary amenorrhea is no menses by the age of 13 with breast development by the age without breast development, age of 15, no menses with breast development. And your secondary amenorrhea is, let's say you don't have a period for 3 months if you have a history of regular periods, and 6 months if you have a history of irregular periods.
Okay.
Okay.
So I had
So
the
what did
ages
go
wrong.
ahead?
I had the ages wrong for the
Yeah,
primary.
I mean, but I don't think it's going to be disastrous. And I mean, I would pass you definitely on this question. Um, so in the end, what's the cause of the patient's amenorrhea? Well, 7 years is a long time.
Right. So the best I could gather is that it was anovulatory from
Wow,
her.
7 years. Okay.
Yeah,
And she had a normal lining on
correct.
ultrasound. You would think that thing would be huge.
Yeah.
Um, your workup was good, correct with the progestin challenge. If it doesn't work, now she's had two children. It'd be different. let's say if she was 15 years old, right?
Yeah.
She has breast development. If you gave her progestin and you didn't see any bleeding, it's either, let's say, the athlete triad, hypoestrogenism, because of,
Hmm.
being an athlete, for lack of a better word, or she has an outflow obstruction. So in that case, the outflow obstruction is correct. So then you go on to the estrogen and progesterone challenge. And if that's negative in somebody who's had a kid before, you have to think of asherman's, because she can't have an outflow tract. If she was younger, she could have an outflow tract. Does that make sense?
Yes.
So I thought your explanation of all that was very good. So I would definitely, you did well in this question. Just the DHES, and now you clarified it, and you won't make that mistake again.
Okay. Yeah. Thank you.
All righty. Other questions? Very good job.
No, that was it. Thank you.
Very good. Oksana, I'm going in your direction. Are you there?
Yes, hi everyone.
Hi, how's it going?
Good, good. How are you?
Very good, very good. And just for the next person is going to be Natalie. Okay, so Natalie, be on standby. A specific case or section that worries you?
I mean, I prefer to do GYN or
GYN. Okay.
office if possible.
Okay. Let's do some GYN. Are you a subspecialist or generalist?
Yeah, yeah, I'm a MFM fellow.
Ooh, okay, okay, all right, okay. Let me look for your list here. Give me a second. No, it keeps giving me the wrong case list. Give me a second, my friend.
Yeah.
The hardest part is finding these cases, these lists. It's like you need a PhD for that. Did you turn in your list?
Yeah, I sent it, so it should be somewhere in the
Okay,
system.
I do not see it, because you should be one of the last ones on the list because of your last name. I don't see it. Did you turn it in August?
I mean, I joined in August, so in
Okay, let me see. Let me see.
sometime in August, I did send my all three lists.
Let me see. Let me see.
Mic off.
I don't see it, so bear with me a second. Let's see what we got here. Hold on a second. Technical difficulties. August. Let's see that.
But it's okay if you want just to maybe pick some topics, so kind of like,
It's not here. I can do
similar to.
topics. Sorry, your list is not here. I looked at it
Yeah,
and
that's okay.
by
We
your
can
first
just.
name and your last name, so my apologies.
That's okay. We can just do some topics.
Um, I'm just thinking of some things here. So give me a differential for abnormal uterine bleeding.
So with abnormal uterine bleeding, I usually go by palm coin system. So I usually try to think about structural causes such as polyps, adenomyosis, hyperplasia or malignancy, um, uh, leiomyoma, and then non-structural causes such as coin system, so coagulopathy, ablation issues, iatrogenic, then endometrium, and non-classified.
Can you give me an example of something that could be not otherwise classified?
I don't think I kind of like it's something that doesn't feed other categories. That's how I would.
Can you give me just something that won't fit any other category?
Um, like idiopathic when other causes were ruled out?
So you say you have a patient that comes in, she has abnormal uterine bleeding, and really, you can't really find a good reason that it's going on. Her labs are fine, she's normal weight. So can you just give me an entire overview of the different treatment options you would discuss with the patient, talking about medical and surgical? Go through your process.
So out of medical options, I would have available oral contraceptives pills, and progesterone pills. I mean, not necessarily pills, but in different forms. So it could be intrauterine progesterone system. Then if also endometrial ablation and that option.
So what are contraindications to an endometrial ablation?
So pregnancy will be contraindication, then abnormal size of the uterus, like big uterus, greater than, I believe, like 10 centimeters, distorted shape and of the uterus with a large submucosal fibroids, for example. Then history of prior, I believe, like multiply cesarean section, where do you have concern of very thin myometrium, and there is a concern that upon procedure you may have any sort of injury to surrounding organs. Any intrauterine issues like Asherman syndrome, and a postmenopausal status or abnormal uterine bleeding that was not evaluated and cause was not established for the bleeding.
Now, can you tell me about the different endometrial ablations that are available? Do you know of one method versus another? And can you explain how it works for me?
Yeah, I think in prior like time of development of medicine, like Hurl Bowler kind of a type of ablation was the gold standard, where you kind of like physically burn with a like thermal energy and burn the endometrium, and then radiofrequency type of ablation, which is example will be NovaSure device. Then hydrothermal ablation, when you use a thermal balloon and apply energy of fluids that circulate in that balloon.
So let me ask you, can you tell me what are pros and cons of the NovaSure?
So NovaSure is, I think pros will be that is an endometrial ablation procedure. I mean, it's effective type of endometrial ablation. It's a disposable device. I mean, it's expensive, which is cons. It's burn entire endometrium, and it can cause like agglutination of endometrial cavities. So it's probably not the best choice if you potentially may need a resample patient at some point. It's not really well applicable to different shapes of the uterus. So if you do have maybe small distorted like a uterine shape cavity, so that may not work. For the huge size of uterine cavities, it may not work well. So that will be downsides of this type of ablation. I think it's relatively easy in use, so which is good for providers. It's probably relatively easy to learn how to use for the learners. Let me think what else.
Now, do you have to prime or prepare the lining for a NovaSure ablation? Why or why not?
So no, I don't think you need to use special preparation for endometrial lining for NovaSure.
Why is that?
I think the depth of NovaSure ablation is about like 4 millimeters. So and it's used like radio frequency energy. So my understanding that it just allow you to like vaporized the tissues without any additional like needs to special prepare them. So
Can you tell me pros and cons of the hydrothermal ablation?
So if I recall correctly, the really big advantage for those devices will be is that you can use for the bigger size of uterine cavities. You can also use for some distorted cavities when there is a small deformity from like submucosal intrauterine fibroids. It does use a thermal energy of heated fluid. You can also control the process of thermoablation. And I think the downsides and concerns will be that you use that heated fluid, so it can leak during procedure if you like don't follow instructions. So potentially you can have a thermal injuries. It's a little bit longer in duration, a little bit, I would say, more complicated type of system for the provider and learners. That's probably what I can think about.
Do you have to prime the endometrium with the HTA, with the hydrothermal? Yes or no?
I think no, but I'm not sure.
And go back to how you would treat the patient with her abnormal uterine bleeding.
It depends on the causes of abnormal uterine bleeding, and
so let's say we didn't find a cause. Her workup was negative. She wants some type of treatment. So we were talking about medical. You brought endometrial ablation. What other options are available?
Yeah, OCPs, progesterone. Yeah, OCPs and progesterone therapy will be the most likely that I'm going to use.
Anything else? Can you give me more specifics on progesterones?
So we can use like different type of progesterone that can be used like PO, like Provera, and or you can use intrauterine devices that deliver progesterone locally to endometrium.
Can you go into the details of the different types of IUDs that are available?
So the main two groups, IUD, non-progesterone and progesterone containing. So non-progesterone IUD will be like Cooper IUDs, and progesterone container system like Mirena or Liletta or Kyleena.
Can you give me some specifics on the amount of medication in them? How many, what's the difference between them?
So Mirena has 52 milligrams of levonorgestrel. I'm not sure about the other ones. Haven't been working with them.
So if a patient has some issues with abnormal uterine bleeding, which IUD would you recommend?
I would recommend Mirena since I have been working with this IUD more often than others.
So let's say the patient wanted the Kyleena. Would that be beneficial?
I think they all works exactly the same. I think the main difference is with the size of device, and that could be something to consider.
So what you're telling me that the amenorrhea rate for all progestin IUDs is the same?
I would need to look that up.
Okay. Anything else you can give progesterone wise or progestin wise?
You can consider using depot injections, or you can consider a Nexplanon placement. However, I would not recommend Nexplanon for the purposes of abnormal uterine bleeding, since it can influence regularity and amount of bleeding.
Let's say the patient tells you, doctor, I'm not interested in hormonal treatment. What other options are available, if any?
If I think it depends. If it's just a heavy menstrual bleeding, tranexamic acid could be things to consider, but it will not help patient if patient has irregular menstrual cycle.
And what's the dosing there?
So usually it's 650 milligrams TID for 5 days during the menstrual cycle.
Okay, let's stop there. What'd you think?
Oh my God, it wasn't challenging. I feel like I forgot.
I thought for because you said you were an MFM, I thought you did really well. The you always go to your palm coin, always go back to your basics. That's easy questions, easy points. You don't want to lose those points. For not otherwise specified, I think of AV malformation. Where would else that where would that fit anywhere?
I couldn't recall what they meant, but by that, like non-specified. So I thought it's like
Right.
really when you're looking on everything and you kind of like don't see any causes and okay.
Yep. I mean, I'm very impressed you knew about the two different types of ablation systems, because some people only know about the one that they use, and that's why I asked, which one do you use or which ones do you know about?
Yeah, we actually use in residency, so that's what's helpful.
Very good. So just a couple of things for clarification, but I thought you did very well. Contraindications: hyperplasia, cancer, active pelvic infection, you have an IUD in situ, prior transmyometrial surgery, any congenital uterine anomaly, a uterine length greater than 12, menopausal, severe myometrial thinning, and of course, any desire for future fertility. The patient should be on some type of birth control. The NovaSure is bipolar radio frequency. It's very easy to use. It's very quick. It does not require endometrial preparations, as it adjusts the ablation depth by measuring tissue impedance. So you do not.
Mm-hmm.
Now, the HTA is a little bit different. The HTA is more beneficial in the sense, even though the FDA doesn't really give approval for any of them for this indication, but HTA kind of says we can do that. So if you have any polyps, impinging fibroids, you can use it because the fluid circles around or circulates, so it'll go through all the different areas, while the NovaSure, the fan gets out, and if you have fibroids, you're not going to get to that area. It's performed under direct visualization, can be performed with intracavitary lesions. Disadvantages: you have more pain because the hot water stimulates pain from the nerve fibers in the myometrium. You could have external burns. You said you could get burned because the water will fall out of the vagina. You do need endometrial preparation. So if you don't prepare the endometrium, so that's giving them progesterone, the birth control pill, giving them Lupron, something to thin out that lining, you're going to burn something that she's going to slough off, so it's not going to be as effective. I like your explanation. Now with the IUDs, be very, very, very careful, because the IUDs is the best IUD is going to be the 52 milligram when it comes for amenorrhea or abnormal uterine bleeding. Usually those are good for 5 years, even though the Mirena IUD is good for 8 years for birth control. For AUB, it's for 5 years. The levonorgestrel has 52 milligrams. The Kylena of levonorgestrel, Kylena is 19.5 milligrams, and the Skyla is 13.5 milligrams. So if you want best effect, it's going to be the Mirena. So amenorrhea is 20 to 40% roughly with the Mirena and Liletta. The Kylena is 12 to 20% amenorrhea rate, and the Skyla is 6 to 12%. Make sense? Did I lose you?
Yes, no, I'm here. Thank you. I was just muted for a second.
And for the TXA or the Listetta, it's 1300 milligrams TID for those 5 days.
Yeah, I kind of like figured it out, but I made a mistake. It's probably 652 tablets TID. Okay, now it makes sense.
Other questions? I think you did a nice job. Any other questions?
No, I don't have. Thank you.
No, good job.
Thank you.
So if anybody has any questions, put them in the question box. We'll try to answer them. And I'm going to be going to Natalie's direction here. I know she was here. Says you're self-muted, Natalie.
I'm here. Can you hear me?
Yes. How are you doing?
I'm good. How are you?
Hey, living the dream. Or living the nightmare. I don't know. Are you generalist or subspecialist?
I'm a generalist.
Okay. Anything specific you're looking for? I'm gonna see if I have your
Um,
list.
You should have my list, but anything is fine.
Oh man, it's not here. I don't
Really?
see it. And I'm on September. Let me look at it under your last name
Yeah, I think it's under Davis.
and your first name. No. Booger. And I have it like, wow. Did you turn it in August? This is
I
very
turned in
strange.
September and I've seen it scrolled past before.
Well, I'm gonna show you. Unless I'm missing something.
Oh, you're right. It's disappeared because they've gone through my list before.
So I don't know what's cooking. Let me go to October maybe. Or are you taking the exam in October?
I think I'm signed up for October as well, though I'm
Okay,
also
so let me check it out here. Maybe that's the deal. Because I don't know, man. Yep, October. You're here.
great.
Let me see if Oksana was there. I bet you, yeah. No, Oksana was not there. All right. Anything in particular that's worrying you or concerning you?
No, anything is good practice.
So we did office, we did GYN. How about OB?
Sounds good.
All right, let me take a look here. The hardest part is trying to find something on the fly, right?
Mm-hmm.
I'm just looking. Bear with me.
No worries.
Case number 67. So how did you diagnose the patient with chorioamnionitis?
So this patient came in early labor at 40 weeks and 4 days. Decision was made to augment her. She ruptured her membranes at some point in the course, and we noticed that she had a fever of, I believe, 102, along with fetal tachycardia, and therefore made a diagnosis.
And what did you treat her with?
So for this patient, I started her on ampicillin and gentamicin.
So why specifically did you start ampicillin and gentamicin? Can you tell me specifically why? What were you treating?
The ampicillin would be covering gram positives for things like GBS. If we had missed that, though she was GBS negative. And the gentamicin would be covering, I guess, gram negatives. And, yeah.
So let's say the patient had endometritis. How do you diagnose endometritis? How do you treat endometritis?
So endometriosis is a clinical diagnosis, typically seen in the first few days postpartum. Typically, a patient may present with fever or distinct fundal tenderness. In my practice, I treat with gentamicin and clindamycin, though if they were GBS positive, I would also add ampicillin.
And what are you treating with the clindamycin?
With the clindamycin, be treating for MRSA, though I'd have to go back and look specifically.
So the clinda's for MRSA?
Yes.
Now, is there a time frame that somebody gets endometritis versus chorioamnionitis?
So chorio is typically pre-delivery, since it's the amnion. Once the placenta is delivered, typically I think of no longer able to have chorio, and endometritis is typically a postpartum diagnosis.
Is there a time frame postpartum wise? So let's say 9 hours after delivery, the patient has a fever and you feel that it's from the uterus. Is it chorioamnionitis or endometritis?
I'm not aware of a specific time point when it switches from one to the other, but I would say 9 hours after, I would call that an endometritis.
So you would treat her with what medications? Clinda, what else?
And gentamicin.
But if she was GBS positive,
I would also do ampicillin.
why was this baby admitted to the NICU?
In my institution, all babies who are born to patients diagnosed with chorioamnionitis are admitted to the NICU for at least 24 hours for observation for sepsis.
Was there any issues with the neonate?
No, baby was discharged on postpartum day 2.
Anything you do during or after your delivery because the patient has chorioamnionitis?
So if they're febrile, I'll give them Tylenol to try to bring down their fever. And then after delivery, I typically send the placenta to pathology so that it's a pathology confirmed diagnosis.
So did the pathology confirm the diagnosis? In this
Yes,
case?
the placenta came back with acute chorionitis.
So the patient's preeclampsia was diagnosed when?
Also diagnosed intrapartum.
Intrapartum, at what point in the labor?
I believe she was diagnosed in late in labor. She had multiple severe range blood pressures.
So there was severe range. What's severe range?
Oh, sorry, excuse me. Sorry, she was preeclampsia without severe features. So she had multiple mild range blood pressures of 140 over 90.
And anything else that you did in order to rule in or rule out that she had the severe features?
So this patient, for all my patients, I'm suspecting a preeclampsia diagnosis. I send serum labs as well as a urine protein to creatinine ratio.
And what are you looking for on those labs?
My labs, first I'm looking at a CBC to look for thrombocytopenia. I'm also looking at their creatinine to look for a creatinine that's 2 times their baseline or over 1.1. And I'm also looking at their LFTs.
Anything else that you would check on?
On the urine protein creatinine ratio, I'm looking for proteinuria, which would be defined as more than 0.3.
Go ahead.
In my institution, we also send an LDH, so that's not a diagnostic criteria.
Why would you send the LDH?
Looking for any signs of hemolysis.
What is the best test to evaluate for hemolysis?
The best test to evaluate for hemolysis, I am not sure what the best test is. But
what was this patient's PCR, protein creatinine ratio?
it was greater than 0.3.
But you can't tell me what.
I'm not sure of the exact number, no.
Okay. What is the how much etonogestrel does the implant contain?
The implant contains, I believe it can, I'd have to double check actually. Yeah, I'm not sure the exact number.
And what is the mechanism of action of the Nexplanon?
So it's a progestin. Most of the progestin methods, they're thickening cervical mucus. It's one of the main methods, and also thinning out the endometrial lining as well.
So it's thinning out the lining and the thickening of the cervical mucus. It doesn't have any other indication or mechanism of action?
It's a progestin, so patients are not always ovulating, though I don't think you can say for 100% certainty that they're not going to ovulate.
And how long is the Nexplanon good for?
So it's been a bit of a change. Initially, it was FDA approved for 3 years. I recommend patients use it for 5 years.
And so this off-label use is what you're telling me? You tell your patients?
I believe it's now approved for FDA approved for 4 years, but yes, I do use it off-label for up to 5.
Now, is there any concerns? Because I'm assuming this was placed immediately after delivery.
Yes, before she went home.
So is any concerns with her breastfeeding?
No, not with the implant.
So what other birth control methods is there an issue if you're breastfeeding immediately starting
There
upon
can
delivery?
be some issues, I believe, with Depo-Provera with a very high progestin level. And then not so much concerns with breastfeeding, but I don't recommend any estrogen-containing methods immediately postpartum.
Why not?
Because their risk of clot is quite high in the first 6 weeks after delivery. So I don't recommend estrogen at that time.
What about the mini pill, the Micronor, progesterone only?
Micronor progestin only, I do recommend for patients who are interested in a pill method.
And they can start immediately when they leave the hospital?
Yes, they can start immediately.
All right, let's stop there. What'd you think?
I completely forgot all microbiology. It's like I just went out.
I'm sorry, you forgot your what?
Microbiology. It's like what I could not remember anything about antibiotics in that moment.
Oh, we're gonna go over it. You're off a little bit. Before we go any further, Carla, you're next on the list. Okay, so I'm gonna be going to you next. So chorio, this is my understanding. Again, I'm just a generalist. I like what you said, very nice. So your ampicillin is for your gram positives, your gentamicin is for gram negatives.
Okay.
Really, it's a placental diagnosis. You suspect it, but the placenta is the one that kind of tells you, yes, you were correct. Interesting, everybody goes to the NICU with chorio. I'm sure they had a bad outcome at some point, so they monitor
Not
the babies more.
new institution, so it's kind of aggressive, but it's a lot.
Somebody's making money.
Yep.
So to my understanding, endometriosis is a diagnosis that occurs 24 hours after delivery because the vaginal flora changes. Don't ask me how, after 24 hours after the delivery. So at that point, you have more gram negatives and anaerobes that cause issue. So then you do your clindamycin for your anaerobic coverage, your gentamicin for your gram negative. Up to date clearly says if somebody is GBS positive, you should start ampicillin right away with endometritis. When I trained, it was gent and clinda, and the patient didn't improve within 24 hours, you started the ampicillin. I usually start all 3 from the get-go.
Okay.
Okay. What else did I ask you? The preeclampsia without severe features, that was fine. Haptoglobin, to my understanding, is the best
Haptoglobin.
for hemolysis, but it sometimes is sent out, so it takes a while for it to come back. Etonogestrel, I looked this up. It's still the package insert still says 3 years. So the main mechanism of action is it prevents ovulation, it prevents the LH surge. However, after 24 months, the effectiveness of that starts decreasing. So like you said, the cervical mucus and the environment not being conducive for implantation come into play.
Okay.
But to tell you it's for 4 years, I know people have told patients to do that, but the package insert doesn't say that. And I reviewed it maybe a month ago.
So I just say 3 years just to not get into deep water.
Into the weeds.
Okay.
To my understanding, and I am not an expert in breastfeeding in any way, shape, or form, you don't want to give Depo. You want to give Micronor. You definitely want to give OCPs because of the reason you said. But you may affect the breastfeeding, supposedly. Do I give it to patients? Yes, if they want it. Even the Micronor, there's concern that there could be an effect on the breastfeeding. But you taught, and I trained many moons ago, and we would give patients, combined oral contraceptives as soon as they walked out of the hospital. And there was the concern that it would decrease breast milk supply. And some people are of the opinion that it did not. It depended who you spoke to. But now you don't give it because of the increased risk for VTE. Anything else?
I don't think so. I'm glad we did the
Okay.
antibiotic.
Okay, very good. Very simple. But those, you want those simple ones. Sometimes
Yeah.
you forget the basics. But no, good job. Good job. I would still pass you.
Okay, thanks.
Okay. Other questions?
No, I think that's it.
All
Thanks
right.
so much.
Great job. So Jose's asking, does Kylena have FDA approval for AUB or only Mirena? To my understanding, Mirena, I would have to look at that. I mean, you can give, I guess, an IUD for anybody, but with the understanding, if you want the best benefit, Jose, for control of your AUB, it would be the Mirena or the Liletta, the higher dose. As long as the patient, to tell a patient they all work the same, not necessarily true, because the amenorrhea rates are different. So that would be a factor more for AUB, you know. But if a patient wants a Kylena, you say, hey, you can get a Kylena. It's, 6 to 12% risk of amenorrhea. Hopefully it'll help you. It may not. If you want that for more effect to control your AUB, you want the Mirena because it's the higher level. Okay, so Carla just told me she is unfortunately driving, so she will not be able to participate. So let me just look at the list here. And if anybody has any other questions, please, chime in with the question mark. So I saw Kia was here, but I don't know if she's still here. I'm just looking at my list and who's here. So I think she's offline. If you are here, Kia, put your hands up. Chihiro, I see you're here. I'm going in your direction. So I have Oksana adding here. I saw in the instruction for Nexplanon that it is not allowed for placement 21 days after delivery, VTE risk. We did that all the time in residency. Place Nexplanon before discharge from hospital. Again, I think a lot of these companies, they cover themselves. So some of the newer stuff's like, don't give it to anybody because of the, it is progestin. I do know if you speak to a hematologist, if somebody has a fresh VTE, they frown upon giving anybody any progestin medication. Even though as obstetricians, gynecologists, we say it's okay. Again, I'm not an expert. That's an area of like vagueness, and you can just defend pro and con, right? She won't get pregnant as long as the patient shared decision making understands there's that risk. Are you there, Chihiro?
Yes, hello.
Hi, how are we doing? How's it going?
Oh, just hanging in there.
Hey, that's all you can do, right?
Yeah.
Any specific section you're worried about? Doesn't matter. Let me go back
No,
to
it
my
doesn't
October. Say again?
It doesn't matter if you could just pick a random
Okay.
case.
So
that'd be
let's
great.
go to office. I'm just going in line here. If that's okay.
Mhm.
Let me just go back to the September dates. Hold on. Weird that they weren't there before. So is Elizabeth still on the call? I'm just trying to see who's next. Give me a second. So I think Elizabeth is off the call. I do see, like I found Kia. Kia, You're going to be next. Faraz, you're going to be next, okay? I see you. You're going to be next, okay? Because you weren't there before, and I had seen you earlier. It's like I need a PhD just to call, look at the list. It's so long. All right, Chihiro, we got you here. We said office, correct?
Yes.
No particular case worrying you or anything?
No.
Let's see what we got here. Case number 31. So discuss with me how you underwent the treatment option counseling for the patient for this undesired pregnancy.
Yes, so this patient came in with a history of amenorrhea, and we found that she was indeed pregnant based on a urine pregnancy test and a ultrasound as well. So at our practice, we do not offer termination just for insurance reasons, but it's still one of the options that I do discuss with my patients. And so,
Can I just ask what you mean by insurance reasons?
well, to my understanding, we do not do surgical DNC procedures with a fetal heartbeat.
Your reimbursement is less or something?
I that's what I'm told, or I'm also it's also my understanding that the hospital that I work at, as well as the surgery center that we are contracted with, they do not allow us to do DNC. Okay. We only do DNCs for the purpose of like a missed abortion or like something like that. So it's something that I can't offer to my patients just because we're not contracted to do that. But it is it's an option that I do discuss with my patients, especially if this is not an undesired pregnancy. So in the city that I live in, there are multiple abortion clinics that do offer medical abortion as well as surgical abortions. So I sent her to one of those clinics.
So can you, so what other discussions do you undertake with the patient? You said, you yourself don't do surgical terminations. Anything else you could discuss with the patient?
Yeah, so I discussed with her that when she goes to the abortion clinic, most likely they're going to discuss with her medical abortion or surgical termination.
So let me ask you this. What situations would a surgical TOP be more beneficial than a medical TOP?
So if after counseling, if that's what the patient desires, if I believe the abortion clinics do not offer medical abortion after I believe it's either 12 or 13 weeks of gestation.
So let me ask you this before you answer that question. Can you tell me the protocol for a medical termination? What medications are used? What's involved?
Yeah, usually there's mifepristone that's used, and then 24 hours after Cytotec or misoprostol is administered.
And can you give me some dosing?
Yes, mifepristone, I believe, is 200 milligrams, PO times 1, and then misoprostol is I believe it's 400 micrograms PV or bucally.
And you said up to how many weeks or days is it effective to for termination? FDA approval?
To my understanding, it's 12 or 13 weeks of gestation. I want to say 12 weeks gestation.
Okay. So what is mifepristone?
Mifepristone is an anti-progestin.
And can you give me a little bit more information? Like, what does it do?
So to my understanding, it's an anti-progestin, so it prevents the pregnancy from continuing. I will say mifepristone is a little bit hard to get in in some of our clinics as well. But to my understanding, it's an anti-progestin, and it stops the pregnancy from going on.
So what are contraindications to its use?
I would have to review the full list of contraindications. One thing I would think of is if the patient has an allergy, if the patient does not desire medical management, if the patient is, those are the only two I'm aware of. I would have to look up the contraindications.
So let's go back to what patients or what indications are preferred for a surgical terminations versus a medical, and vice versa.
I'm sorry, can you repeat? I'm sorry, you cut off a little bit. What was the question?
Sure. So going back to the original question, there's some situations, medical, for the patient, diagnostic wise, that she would be a better candidate for a medical termination versus a surgical.
After discussing the risks and benefits of both, if the patient desires a medical termination because she can pass the pregnancy at the privacy of her home with her family or by herself, if that's what she desires, then a medical termination is indicated. The medical termination can also only be offered, I believe, in the first trimester as well. So that's why I was mentioning, I believe it's only FDA approved until 12 weeks of gestation.
So you can't tell me of an indication where you think a surgical termination might be more beneficial than a medical?
Well, surgical, so if the patient does not want to proceed with medical termination.
So you're saying it's more patient preference?
No. Also, okay. After the second trimester, surgical abortion is indicated.
In the beyond second trimester. So let me ask you this. Let's say the patient is a Jehovah's Witness. Would you be okay with her having a medical TOP?
I would, that's something I would discuss with her. If she has a medical abortion, then, that she is at higher risk for some blood loss. And in the event that she has retained products, she can have continued bleeding where she may need blood products. I see what you're saying. If the patient is already anemic or does not want blood products, I think that would also be another reason to proceed with, to recommend a surgical termination over medical termination.
So what if the patient had a congenital uterine anomaly? What would be the best method?
In that sense, I think the better option would be an ultrasound guided surgical termination.
So you would do a surgical termination. So I'm changing the topic completely. Can you tell me different congenital uterine anomalies that can occur?
Yes, you can have either a Müllerian agenesis, where you don't have a uterus. You can have a uterine.
But she's pregnant, so let's assume she's pregnant.
Sorry, I didn't know we were talking about.
I got you there, but that's good. You can go that just in general. Good point.
Okay. You can also have a uterine didelphys. You can have a bicornuate uterus. You can have a uterine septum. You can have an arcuate uterus.
So let me ask you, how would you differentiate between a bicornuate and a septate uterus?
So we would be able to see on a imaging such as an ultrasound or an MRI in that sense would be probably better imaging to differentiate between the two.
Let me ask you, what would be the gold standard?
I believe the gold standard is an MRI.
Okay. Anything else better than an MRI?
Mm. I can't think of a better imaging than an MRI. Oh, I'm sorry. Oh, I guess you can also evaluate for the uterine cavity with a hysterosalpingogram.
So if you do a hysterosalpingogram, what would it show you?
If you do the hysterosalpingogram, it would the bicornuate uterus would show you the two uterine horns and the two uterine cavities. And
But
then,
would you be able to differentiate between a bicornuate and a septate uterus?
I think it would be a little difficult.
So then what would you have to do?
I mean, I would still think that an MRI is better.
All righty. Now, if somebody has a congenital uterine anomaly, what other organ systems could be affected?
They can have renal anomalies as well as skeletal anomalies.
And in what percentage of patients, if they had a congenital uterine anomaly, would have a renal anomaly?
I'm not sure of the exact percentage. My guess would be around 30 to 40%.
Which side would be affected if you had a renal issue with a congenital uterine anomaly?
For some reason, the right side comes to my mind, but I would have to look that up and discuss that with somebody who has a little bit more experience with Mullerian anomalies than me.
And you said arcuate uterus. Are you at greater risk for issues because of an arcuate uterus?
For arcuate uterus, I believe you're at slightly higher, if you are pregnant, you're at slightly higher risk for fetal malpresentation, as well as preterm labor.
Okay. All right, let's stop there. What'd you think?
I thought that was hard.
Oh, really? Okay, sorry.
No, that's good. Hard is good. I'd rather get hard questions now than later.
I'm just a generalist, not that I'm an expert, but to my understanding, according to the FDA, mifepristone is up to 70 days or 10 weeks.
Okay.
Okay. And the earlier, of course, the more effective it is. It is 200 milligrams PO with 48 hours later, the Cytotec 400 micrograms PO, and you check 14 days later, 92% effective if less than 49 days. But again, it could go up to 70 days or 10 weeks. To my understanding, if you think there's going to be some difficulty in the surgery, it's preferable to do a medical termination, multiple fibroids, congenital uterine anomaly. Do you really want somebody bleeding at home that you can't control if she's Jehovah's Witness or she is on some type of anticoagulation?
Right.
Okay. I'm trying to remember in my mind, twin gestation is not a contraindication. I could be wrong for a medical termination. I could be wrong though. My apologies. It's a much harder surgery. And you should do it under ultrasound guidance because you can leave the other one behind, right?
Right.
Mifepristone is a derivative of norethindrone. It binds to the progesterone receptor with an affinity greater than progesterone itself, but does not activate the receptor, thereby acting as an antiprogestin. Its known actions on a pregnant uterus are the following: decidual necrosis, cervical softening, increased uterine contractility, and prostaglandin sensitivity. This is directly from the practice bulletin. Contraindications to mifepristone. It is a glucocorticoid receptor antagonist, so it is contraindicated in patients with chronic adrenal failure, who are on concurrent long-term corticosteroid therapy. Should not be used by women with hemorrhagic disorders or who are on medications that interfere with hemostasis. So this may lead to heavier bleeding during the termination. It is porphyrinogenic and contraindicated in women with porphyria, because we see porphyria on a daily basis, of course. The best modality to identify a septated versus a bicornate uterus is a 3D ultrasound, because you can simultaneously see the serosa and the uterine cavity contours at the same time. So if you do an HSG or you do a hysteroscopy, you will see something inside the uterus, right? But you cannot differentiate if it's a septate or a deep bicornate, right? You just see that there's something there. So really the gold standard before we had 3D ultrasound and MRI and all that, I'm not saying MRI is not wrong, but the 3D ultrasound should be cheaper, right? And this is what Up to Date says, and I've heard from REIs that is correct. 3D ultrasound. You can do a scope, do a laparoscopy. If you see the heart-shaped indentation to the fundus, that's a bicornate uterus. If it's a smooth fundus, it's a septate uterus. What other organ systems could be affected? Abdominal wall, inguinal hernia, renal, skeletal. 20 to 30% renal anomalies. If you have a congenital uterine anomaly, which side is affected? The anomaly is present typically ipsilateral to the anomaly. I don't know how bicornate works, because that's the same. An arcuate uterus is a variant of normal, so you should not have an increase of any issues.
Okay.
Okay. And to my understanding, if somebody has a septate uterus, they break it down hysteroscopically and make it arcuate. They don't go all the way. Because in the old days, you would have to go up with a laparoscope as you're cutting to make sure you don't go through the myometrium and through, because you didn't know how deep to go. Again, I'm just a generalist. Okay. But I thought you did good. Good job.
Thank you.
But that's why I asked it, because not too many discussions on termination. Because you have to have a special license and all that good stuff. But theoretical is a good discussion, right?
Right.
To my understanding, if you go to Planned Parenthood, it costs the same to have a medical versus a surgical termination. I'm not an expert, but it's like $800.
Yeah, it's about the same here.
Okay. All righty. But great
Thank
job.
you.
All righty.
Thank you.
Faraz, I'm gonna go going in your direction. So I'm gonna name the people that are on the list. Please raise your hand, because after Faraz, there'll be only one more spot left. Daniela, I don't see her online. Kyla, online. Carla's not available. Pamela, Chibi, Amin, Ashley, Mary M, Yasmin, and Elizabeth. If any of you are on the call, please raise your hand. You'll be after. I'm sorry, Ashley. It's Ashley S. My apologies, Ashley, but I can go in your direction. If nobody is on the call, I'm just looking down the line. Nobody's raising their hand, man. Okay. I have some questions here. If Faraz, we're going in your direction here in a second. So Vanessa said Nexplanon is US MEC category 2 if less than 1 month postpartum. So many will insert prior to discharge based on shared decision making. Thank you, Vanessa. Oksana is saying 3D ultrasound. Natalie said, is it 800 micrograms of misoprostol? I read 400. Could I be wrong? Possibly. This is what I had seen on the practice bulletin. My apologies if it's wrong. Or maybe I typed it. Martina's saying, did we say medical termination is preferable with fibroids or congenital uterine anomalies? Some people believe it is preferable because you can run into difficulty doing the termination surgically. Okay, I read that in the Up to Date article. You know, you end up reading a lot of different things. Any other questions, just put them in the line. If somebody wants to check to see if Natalie's correct, it's 800 micrograms. I'm sure somebody can look up medical termination and they'll tell you that, but I believe I got this straight from the FDA, but I could be wrong. And it could be a couple of years old. My apologies if that's the case. It's always hard to stay current. All right. So Clarissa's saying 800 is correct. Natalie's saying the practice bulletin is 800. My apologies. I'm going to fix it in my paperwork. Apologies. Thank you very much. I do not do this regimen in any way, shape, or form. So 800 it is. Thank you, guys. Farnaz, I am in your direction here. It says you're self-muted.
Can you hear me?
Yep, I can hear you.
Great.
Oksana's saying it's mifepristone 200 milligrams. I know the mifepristone is 200 and then 800 of meso. So you have 3 people who have checked it. So my apologies for being an error. So are you a subspecialist or a generalist?
I'm a generalist.
Any specific
Can we do
question,
office,
case that you're
please?
concerned about? Office, you said?
Yeah. Yep. No specific case on office, just any office.
Did I just like black my screen? Was my screen black the entire time or were you seeing the list?
I can't see the list, but I'm on my phone and
No,
I'm on
but
the
did you
whole
see the one before? Did
Oh,
you see
I
Chihiro's?
did. Yeah, I
Oh, you
did.
did? Okay, okay, sweet. Okay,
Yeah.
sweet. Because I was like, oh. Now, did you give your list? Because I don't see you here. Oh, great. Here you are. Perfect.
Yeah.
And I feel like, do I know how to speak English? 'Cause they were missing a couple. All right, bear with me a second while I find something. Okay. Case number 16. So what is the minimum criteria for diagnosis of PID?
The minimum criteria for the diagnosis of PID is a sexually active female with some type of pain, whether it's adnexal, cervical, or pelvic pain, any type of pelvic pain.
And how would you treat somebody on an outpatient basis?
So on an outpatient basis, with this particular patient, I gave her, or with any patient on an outpatient basis, ceftriaxone intramuscularly, and then a 14-day course of
Can you give me
doxycycline.
can you give me specific dosing?
Yeah, sorry, 500 milligrams IM times 1 with a 14-day course of doxycycline 100 milligrams BID and metronidazole 500 milligrams BID.
For how long would you give the doxycycline and the flagyl?
14 days.
Okay. Now, any situation where you may give a higher dose
I would
of
give
the
a higher
ceftriaxone?
dose. I would give a higher dose of the ceftriaxone for weight. I believe it's if they weigh greater than 150 kilos, then you give them 1 gram.
Now, what are deciding factors of admission for PID versus outpatient? So inpatient versus outpatient management.
Some criteria for inpatient management would be someone that was pregnant or immunocompromised. If you're unsure of your diagnosis.
Let me interject here. Let me interject here. So you're telling
Sure.
me if somebody's HIV positive, immunocompromised, she needs to be admitted?
Yes.
You sure about that?
Yes.
Okay, continue.
If you were uncertain of your diagnosis, so if you had generalized peritonitis or severe symptoms, if their white count were to be very elevated, or if they were to have had recent instrumentation of their uterus, if you
So
had
let's say
concern,
the patient had a DNC and you suspect she has PID, endometritis. She needs admission.
correct.
Okay.
Or if I was concerned that someone had a tubal ovarian abscess, then I would also admit them for IV antibiotics.
How would you treat parenterally?
Parenterally, I would treat with ceftriaxone 1 gram every 24 hours, and then I would do doxycycline and metronidazole as well. And sorry, some of the other criteria for my inpatient admission that I forgot to mention is if someone was unable to tolerate PO antibiotics, or if they failed already an outpatient course, so if they weren't getting better with the outpatient antibiotics that I prescribed, and then inpatient wise, I could either put them on PO or IV of doxycycline or metronidazole. I tend to do PO if they can tolerate, and if not, then I would do IV.
And why PO versus IV of both doxy and plasma?
So I would do oral if they can tolerate it, just as it's an easier transition for them. I would assume when they go outpatient, because they're not going to stay inpatient for the whole 14-day course. However, if they're unable to tolerate oral antibiotics, then I would put them on IV metronidazole and
Is there
doxycycline.
any difference or any benefit of giving it, let's say if they're tolerating PO, IV versus PO?
I don't believe so, no. In terms of efficacy, I don't think so.
No? Why is that?
I'm not sure. It's the same dose, same medication.
Now, let's say the patient had an IUD in place. How would you manage that situation?
So I would leave her IUD in situ. If she was clinically improving, then I would continue to leave it. However, if she wasn't improving and she continued to have fevers, like 48 to 72 hours with the IUD in situ, then I would remove it.
You remove it in how long? I'm sorry, I hear background noise, so it's hard for me to hear.
Sorry, I'm on the labor floor.
Yeah, no worries.
But if she wasn't improving in 24 to 48 hours, then I would remove it.
What vaginal cultures and STI screening did you do on this patient?
I did a vaginitis panel and a gonorrhea chlamydia on her.
Any other?
So it looked for bacterial vaginosis trichomonas in Canada. And then I did a full STI. Sorry, go ahead.
No, go ahead.
I did a full STI panel on her. So gonorrhea, chlamydia, HIV, syphilis, hepatitis B, hepatitis C.
Now, seeing that she has PID, is there any concerns that her partner should be treated?
Her STI panel actually came back negative. So I was not concerned about her partner.
Now, in regard, so what is PID? Let's say she has not had instrumentation or anything. She comes in, it looks like she has PID. What are the concerns? Like, what is the cause of the PID?
So most of the time it's ascending vaginal, it's polymicrobial, ascending vaginal bacteria that can cause the pelvic infection and inflammatory disease. It's a particular concern for women of reproductive age, as it can cause pelvic adhesions and tubal damage as well. So that's why it's very important to treat it.
But does it commence as a sexually transmitted disease or not?
Not necessarily, no.
So what would be the cause?
Wait, Nicole, you just said you're 35 weeks pregnant?
So vaginal bacteria, polymicrobial vaginal bacteria, ascending bacteria. So bacterial vaginosis can be a common cause of it. Although gonorrhea and chlamydia are causes of PID as well, it's not the only cause of it. Staphylococcus.
So, seeing it's you're saying it's polymicrobial. Here's a question: can a nun get PID?
Yes.
In what way?
Well, you said a nun?
Yeah. Somebody's never been sexually active, I'm assuming.
So,
I'm gonna bother everybody at least once a show.
I then no. Yes, I believe you have to be sexually active to get it.
But anyway, now I'm done.
But not necessarily sexually transmitted to get PID.
I feel like I want to show everybody, but
Correct.
I always hate the moms that are always showing everybody.
Let's say the
all
nun
videos
douched
of
on a
their
daily
kids.
basis.
Because it like gets too
Would
much.
that
Then
change
I think
things?
yes, then I think that she would be susceptible because she could have some of her vaginal bacteria ascend her genital tract.
Yeah.
But you're saying it's polymicrobial, not one bacteria versus another.
Correct.
I know.
It can be.
I would.
Yeah.
I just don't want to be like, I love you, but I don't care. Also.
Alrighty, let's stop there. What'd you think?
Like, I don't know anything about PID.
Oh, I think you did good. A couple of things I want to kind of tweak on, and it's funny because the question I'm bringing up with the nun and all that, because I trained that when somebody has, and I could be completely wrong. I haven't had time to review this. I have read in the past, and I believe it was CDC who recommended this, but this was several years ago, so I can't say it's current. That if somebody has PID, the recommendation would be that the partner should be treated empirically for like gonorrhea and chlamydia. I remember reading that.
Even if they don't have gonorrhea and chlamydia?
Right. Because the concern is he a harbinger of something? Again, I've not read that recently. This was a while back. I remember just reading about it. Maybe I dreamt about it. I don't know. But I remember it, and I found it kind of odd because I never did that ever in residency. And the way I trained over 20 years ago, was that at some point she had gonorrhea and she had chlamydia. It just now ascended, and now it's polymicrobial. And and it's possible your gonorrhea and chlamydia will be negative. But then I had a discussion with a colleague of mine, because we're doing a lot of cultures for a lot of PPROMers, because we have a lot of early PPROMers, and now they're considering mycoplasma and ureaplasma as a sexually transmitted disease. So we're getting a lot of E. coli and stuff like that in vaginal cultures. So she's like, well, that's why these people are getting PID. So then I'm like, well, can a nun get a PID? Because I'm sure a nun could possibly have E. coli in her vagina, because that's why you have GBS, right? It's close to the,
Yeah.
so I got very confused of my understanding of PID. So do I know the answers to what I asked you at the end there? No, but I wanted to see. They're going to ask you questions that they're not going to know the answer to. Now, I try to give you questions that I know the answer to so we can learn something from it.
Yeah.
Of course, from a generalist perspective, but I'm not an expert in any way, shape, or form. But to my understanding, admission for PID would be severe clinical illness, TOA, nausea and vomiting, pregnancy, no response to outpatient treatment. Age is of no factor. Prior instrumentation is not any factor. Immunocompromise is not any factor. It used to be, but not anymore. This is what I read, unless something changed all of a sudden in the last year in regards to PID.
Okay.
Now, if the patient's not responding, would I follow up somebody who's immunosuppressed more closely? Yes. To make sure, she is responding appropriately. Doxy and Flagyl have the same bioavailability, IV or PO. Doesn't matter. That's why it doesn't matter how to take it. Unlike Clinda has to be IV. Ceftriaxone has to be, well, they're not PO anyway, so you can't give Keflex, let's put it that way. You're correct, the IUD in situ, she's not improved in 48 to 72 hours. It should be removed. This is as per CDC recommendation. It does, in the old days, you had to remove it right away. That's not the case anymore. Your dosing was correct, greater than 300 pounds, roughly. It's a 1 gram IM dosing. Did I miss anything? So I don't have any answer to you in regards to, but I just remember reading that a couple of, the nun question. That's a good one, right? I don't know. You got me. Okay. All righty. But I thought you did good. Correct what you said. Very, very low bar for the diagnosis of PID. According to the CDC, you must be sexually active, have lower abdominal pain, and one of the three: cervical motion tenderness, annexal tenderness, or uterine tenderness. Very low bar, very, very low bar, because the consequence of, infertility is so high. With each PID bout, it increases that risk of infertility.
So the recommendation is to treat partners for gonorrhea and chlamydia if you're
This is what I read in this. That's what I read in CDC a while back. I can't comment
Okay.
that that's true now, but that's
Okay.
that my colleague said that, it triggered. Well, it just made me kind of question what is PID. So I have to do some deep dive on that, because I'm thinking, oh, you got E. coli in your vagina. I can understand if you're douching, you might be doing some pushing things up. That makes sense.
Yeah.
But I don't have an answer, to be honest with you. I was just being snarky to see what you would say.
Okay, sounds
Which
good.
they
I'll
can
look
do, of
into it.
course. Yeah.
Okay.
But I remember reading that once, and I was like, well, I've never done that. We never talked about it when I was a resident either.
Yeah, we never did that either. Okay.
But when I was a resident, IUD was like an X. Nobody got IUDs, but we didn't have Mirenas,
Okay.
So we always had these patients with really bad pelvic infections with their IUDs that had been in for like 20 years.
Mm-hmm.
Yeah.
Okay.
But this was many years ago. All righty, but good job.
Okay, thanks.
No worries. So I'm sure people are going to have questions. So I'm sure, well, we'll go to the next. I'm going to see if anybody that I called before have their hands up. I'm going to say it one more time. Daniela, Kyla, Carla's not available. Pamela, Chibi, Amin, Ashley S, Mary, Yasmin, Elizabeth. Anybody on the call? I'm just looking. Raise your hand. Put your name in the question box. So I have a couple of questions here. I'm going to leave it for later. Rosa, I guess we're off that call, Rosa. Sorry about that. I was having difficulty listening as well. My apologies. So hopefully you guys were able to hear well. Okay, I don't see anybody with their hand up that I mentioned. All right, Ashley. Ashley H, I'm going in your direction.
Hello.
Hey, you won the prize because nobody else is on the call. I don't know what to tell you. You're Urogyne, correct?
I am Urogyne.
Okay, what are you looking for?
OB, if possible.
How did I figure out you were going to say that?
Or office, if you're
Any particular case? No, we did office, so we can do OB.
Yeah. I'm fine with any of the cases.
Can I just do a topic?
Also that.
All right, guess what? You're doing a delivery and you encounter a turtle sign. What do you do?
So when I encounter a turtle sign, my suspicion goes up for a shoulder dystocia. And it's confirmed when I, on gentle traction of the head, am not able to deliver the anterior shoulder. So at that point, I then notify my nursing staff that I have a shoulder dystocia. I have them start the timer, and then I have them get more nursing staff into the room. I also have the patient stop pushing at this point and make sure that no one is applying fundal pressure. I have my nursing staff put the patient in McRoberts position and apply suprapubic pressure on the anterior shoulder in the direction of the fetal face. And then I attempt to deliver again.
Let's say it doesn't work. What would you do?
I would attempt the delivery of the posterior arm.
It doesn't help. What would you do?
At this point, I would perform a wood screw and Reuben maneuver, kind of back and forth, pushing the anterior shoulder forwards and the posterior shoulder back, and then reversing that to try and maneuver the baby down and out of the birth canal. And if that didn't work, I would also evaluate, although shoulder dystocia is a bony process, I would evaluate if I needed further room to make an episiotomy on the skin, on the perineum.
You still can't deliver the baby. What would you do?
So at this point, I would fracture the clavicle of the baby, and I would start with the anterior clavicle.
So how would you fracture the clavicle?
I usually use 3 fingers, and using my 2 fingers on the superior side of the clavicle, I then place my thumb on the posterior side, and I fracture up and out away from the fetal chest and neck.
Why would you do that?
If I fracture inward, I put the baby at risk for vascular damage, nerve damage, and a pneumothorax.
That doesn't work. What would you do?
So after I fracture the fetal clavicle, I do the same maneuvers that I have previously mentioned. If that didn't work, then I fracture the posterior clavicle, and I again try all of those maneuvers. If those have all not worked at this point, I would consider either performing a symphysiotomy or taking her back to the OR for a Zabanelli.
Anything else you could do before you did that?
I could place a red robin around the armpit of the fetus to try and deliver one of the arms.
Something else. Anything else you could do?
That is all I can think of right now.
So how did you use symphysiotomy?
So I make sure that a Foley is in place, and then I displace the urethra away from the midline. I then take a knife and go upward and away from the bladder and cut in the midline of the pubic symphysis.
Would you have to do a Zamanelli if you did a symphysiotomy?
No.
So the symphysiotomy would be pretty successful.
I don't know
Correct or no?
I don't know of any studies looking at the success rates of symphysiotomy.
What is Erb's palsy?
Erb's palsy is a form of brachial plexus injury that is resultant from a defect in the C5, C6.
And what is Klumpke's?
Klumpke's palsy is also brachial plexus injury, and that is in the C8, T1. They both have different nerve deficits and appearance of the baby postpartum.
Now I'm going to change everything completely. We're going to change to another topic. How has heart affected HIV transmission rate in pregnancy?
Heart has greatly reduced HIV transmission rate in pregnancy, and especially if we are able to keep the mother controlled on heart antepartum.
Can you give me some percentages?
So if the patient has no treatment, the risk of vertical transmission of HIV is about 25%. If she has zidovudine during delivery, then it goes down to 8%. If she has a C-section, then it's 2%. And if her viral load is undetectable, then it's less than 1%.
So in what situations is a C-section recommended in an HIV positive woman as a mode of delivery?
So HIV would be recommended in someone who's HIV positive if their viral load is greater than 1,000, or if we had an unknown viral load.
And when would the C-section be recommended to be performed?
Optimally before the onset of labor or before rupture of membranes.
With gestational age. Let's say she's had a previous C-section times 2 and she has a viral load of 2,000.
I would recommend that we schedule her C-section for between 36 and 37 weeks.
What else should you do for a patient who's HIV positive, who's going to go for a C-section because of her viral load?
I would start her on IV zidovudine when she got to the labor floor.
So let's say you have a patient who has a viral load of 1500 and she presents to the labor floor 7 centimeters dilated. Would you do a C-section or would you let her deliver vaginally? Why or why
I
not?
would discuss
Either or.
I would discuss with the patient risks and benefits. In this case, she has already started labor, and so the benefit of taking her for C-section, is potentially less, but there's also still more exposure that she can have going through the actual delivery. And so I would discuss with the patient, and I would recommend that we move for cesarean just in an abundance of caution.
So let's say the patient prefers to have a C-section, a vaginal delivery. Anything that you would not do, avoid?
I would not perform a fetal scalp electrode unless absolutely necessary based on the fetal well-being. I would also attempt to avoid prolonged rupture of membranes, as well as I would attempt to avoid operative vaginal delivery.
Anything else? You said prolonged rupture of membranes.
Yes.
Would go ahead.
If I knew that rupture of membranes was going to affect delivery fairly quickly, then I would do it. But if I knew that she had already had a long labor course, I would not expose her to extra risk by rupturing her membranes.
So you would not rupture her membranes, correct?
Not if I expected it to be a prolonged rupture.
How would you know that?
I think it's difficult to tell, but in someone who's
So
7 centimeters.
let's say she's 5 centimeters. Would you rupture her?
I think if she was on the labor and delivery floor and she was not making change, then it's something that I would discuss with her risks and benefits of this. But I also think at that point, then I would have been discussing doing a C-section with her as well.
Okay, let's stop there. What'd you think?
Thought it was okay until we got into the AROM.
To my understanding, you're not supposed to rupture them. If it happens spontaneously, it happens spontaneously. You're not supposed to do any instrumentation, no FSC, nothing. I'm not an MFM. So let's go over it. I thought your shoulder dystocia was real nice. I was looking at something else. I'm making sure I caught everybody that was on the list. You did say McRoberts and suprapubic, correct?
Yes.
Okay, I didn't hear the McRoberts. I did hear the suprapubic part, so I just want to make sure you had said that. Then you go to your posterior shoulder. You go to your wood screw or the Rubens. Your clavicular fracture. If one doesn't work, you go to the other one. If you think you're gonna have to go to the back, you can be doing what's called the Gaskin maneuver.
Mm-hmm.
Where, do you know what I'm talking about or no?
Yeah, you put her on
she's on all fours,
like elbows and knees.
Right, she's on all fours, and literally you should be doing that as you're running her to the back, so everybody's going to see her backside, and you push towards the ceiling because she's backwards. It's a midwifery maneuver, and apparently it's supposed to work really well. I had a colleague of mine do a symphysiotomy once, and literally it's like butter. The baby just pops out.
Oh, awesome.
Yeah. It was a 12-pound baby, so there you go. They shouldn't have let her deliver vaginally. And as far as a urogyne, I'm sure you know what to do. So you always want to cut up. You want to have a Foley, and supposedly you could put, I guess, is there like a guide wire you could put in the urethra, and you can move the urethra out of the way more by moving it to the side, to my understanding. Again, never done it. They do it a lot in Africa, you know, because they have lack of hospitals or, you know, proper birthing centers. They do what they can because they don't have C-sections that they can perform and stuff like that. Does that exist, like a guide wire to move the
Yes,
urethra?
that does.
Yeah. Okay. So I'm not crazy. Erb's palsy is the waiter's tip. Injury is C5, C6. Klumpke's is the claw, and that's C8, T1. So any questions in shoulder dystocia? So if you do, so you either do a symphysiotomy or a Zamanelli, one or the other. You don't have to do both.
You asked me what the success rate of a symphysiotomy was. Is there a number out there that I
Say
should
that
know?
again? I'm sorry?
You asked me the success rate of a symphysiotomy.
No. It should be almost 100% if you do it right, because it literally opens up the pelvis completely. And then you have to bind her pelvis together. I mean, supposedly it heals slowly, but it heals. But from my understanding, it's very, 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 very successful. Now, when I took this exam, you weren't supposed to give that option, but now it is part of the options. So questions on shoulder dystocia?
No.
But I thought you did really well. You know, as a Eurogyne, very nice.
Thanks.
So heart, had I ever asked you that question before?
No.
Okay, sweet. It's reduced HIV transmission rate from 20 to 30% to less than 1%. Viral load of greater than 1,000. A C-section is recommended at 38 weeks. Okay.
Okay.
A C-section is not recommended if the viral load is less than 1,000. On heart, the overall incidence of HIV transmission is low, regardless of mode of delivery or duration of rupture of membranes. If already in advanced labor or has prolonged rupture of membrane, the benefit of a C-section may be lost. So if she's 7 centimeters, she can actually deliver vaginally, regardless of her viral load, because they believe that you would give her AZT, don't get me wrong. So you want to give AZT with a viral load greater than 1,000. It crosses the placenta rapidly and provides pre-exposure prophylaxis to the fetus. Okay. Up to date says this. Some people disagree with this, but it says a viral load of less than 1,000 on heart in late pregnancy and your time of delivery, and no concerns regarding adherence or resistance to regimen. IV AZT is not recommended, seeing it does not appear to further reduce perinatal transmission. But I know in some hospitals, the patients automatically get it because of the HIV positive status. In MFMs, I think a lot of them said, if you know she's on the proper medication and the viral load is less than 1,000, it is not required. So questions?
I don't think so.
All right, great job.
Thank you.
So I know there's some questions. So let me make sure they're all got answered. So Vanessa's asking, do nuns need pap smears? To my understanding, anybody that was an adult should have pap smears, you know, every 3 years if it's just cytology, with co-testing every 5 years. But I guess also shared decision making, realistically, if it's not, you haven't had relations, but they may have had relations before they became a nun, then she should. But if she's never been sexually active, I mean, cervical cancer, HPV related, I mean, that'd be shared decision making. I mean, because the recommendation is anybody who's an adult should be getting their pap smears. Prachi is saying, if uterine perforation during endometrial ablation, how long is the waiting period before reablation? Ooh, I've never had anybody ask me that question, Prachi. I mean, I would at least say 6 to 8 weeks of healing, you know, maybe even longer, you know. I don't have an answer for you on that one. I guess it also depends on what happened, what was the cause of the ablation, the perforation, if it was kind of the taking out the fan, what do you call it, deployment of the NovaSure. Maybe she'd be a better candidate to do the HTA if you had access to that. I mean, because that deployment, if you ever, it's pretty, it just pops in and you're like, whoa, if you don't have that measurement proper, it could cause some damage. So I don't have an answer for you there, Prachi. I'm sorry. So Mohammed is asking, what answer if they ask, can you get HPV without being sexual, even though recommendation is to get Pap smear regardless of sexual activity? Well, I mean, also, you also have people that use toys. So people are sharing toys. That's the way you can pass the HPV. Okay. So what's the definition of sexually active? Realistically, even if if you have somebody who's never been sexually active, can they get HPV related cancers? No, they can't. Unless there's something weird going on and it's not HPV related. But again, you can find out other things. You should be getting your yearly checkup. I've seen cases where somebody has an abnormal Pap smear, has nothing to do with HPV. It has, or she's postmenopausal, and it shows blood. So that's abnormal. She would need an endometrial biopsy. I've seen cases where somebody has a sarcoma and they have an abnormal Pap, and that's how the sarcoma of the uterus is discovered. So, you know, I don't know what to tell you. You may not be able to get HPV because you haven't been sexually active. If you use toys, that's a different thing. Toys that go inside the vagina. But you can pick up other things on your Pap smear. You know, it's luck. I know of cases where by luck things were discovered, the endometrial cancer or that sarcoma because of the Pap smear. Okay. If anybody has any questions, please put it in the box. I know many of you, this is your last webinar because you have your exam coming up in October, just around the corner for the first group, and then later on in the month for the second group. So I wish everybody very good luck in their exam. And then for those that are taking their exams in November and December, we are still continuing the webinars. To my understanding, we'll be going back to Sunday to Wednesday instead of the Thursday that we added on because we had so many candidates, because so many people were taking the exam in October. It's the first year that they have the 2 weeks taking the exam in October. But I'm sure you'll be getting some notification from Exam Pro in regards to specifics, but I think things are going back to the way they used to be, which is webinars Sunday through Wednesday, Sunday and Tuesday being the case list defense, while Monday and Wednesday being your structure.